Right. Okay. Well, thank you for the invitation and good evening, everybody who's logged in. My name is Dr. David. I'm going to talk about common allergy problems that we see in children and talk about my approach and give some advice around diagnosing and managing. So a little bit about me. I work exclusively at Mediclinic Parkview Hospital in Dubai. I have a master's degree in allergy from 2018, but I see general pediatrics and newborns up to 16 years of age. In the clinic, we do food challenges. So parents who are scared to try foods at home, we do in the clinic. We do skin prick testing if we can. And in fact, there's no charge for that skin prick test, but also do blood tests for which there's a standard charge. And I'd look after all the common allergy conditions, which we're now going to talk about. So really how I want to do this evening's talk is really looking at cases, but just one slide here from the UK, looking at incidence of allergic rash, anaphylaxis, food allergy, and we can see the incidence since the 1990s into the 2000s are going up, and we're still seeing that. So I see lots of children in my clinic with allergies, but also lots of children where parents are worried that there may be allergy, and what are the clues that tell us there's allergy going on. So the first case I want to talk about is itchy skin. So here's this child that I might see in clinic, 11-month-old, dry, red, itchy rash, which can ooze, started on the face. And the main complaint for the parents is that the child is scratching and is unsettled. And of course, if you have a child that's not sleeping at night, it also means the parents are not sleeping at night. And there's frustration there, of course. And one of the things that I find parents are convinced about is that they think there must be something allergic. And if we find what that problem is, the rash gets better. But this is wrong. But what can we do? And here's sort of the child, an itchy rash on the face. You can see the skin here is oozing. And of course, if the child is scratching, not only is the child miserable from all that scratching, it's causing damage to the skin because the skin gets tough and thickened from all that scratching. And parents say, doctor, what's the allergic problem? But eczema is not an allergic problem. It's a skin problem. And actually, when parents come to me and say, doctor, can we do allergy testing? That's not the answer. Okay. Now, what is eczema? So eczema is an itchy skin condition, and it's going on for a while. It's a chronic condition. And the definition is normally there's these situations as well as the itchy skin. It starts early in life, so often before 2 years. The classical areas where it's involved is in the creases, in the arms, back of the knees. The child generally has dry skin, but eczema also has an itch side to it. And there may be some personal history of allergy in that child. So an older child, teenager with eczema, they may also have asthma. They may have had a history of food allergy, etc. There may be history of allergy in the family. It could be one of the parents had eczema as well. And eczema is a genetic condition, and it's a dry skin. Now, the treatment for eczema, really, there's only one treatment, and that is moisturizer. Because what you have with eczema is here we have normal skin. So the cells are nicely bound. There's this barrier in between the cells. They're not too dry, and things do not irritate the skin because you've got this healthy barrier preventing that. But in eczema, the barrier is broken down. The skin is dry, the cells are cracked, and you've got gaps. And this means the skin will get irritated, but not by allergy, by things in the environment which we can't avoid. Swimming, sweat, clothes, heat, sunlight, which leads to sweating and the heat, and soaps. And this will irritate the skin. So the first line of treatment is to moisturize. And by moisturizing, we're replacing that barrier and preventing irritation. But of course, when you moisturize the skin, there's no moisturizer that lasts all day. You need to keep doing it. Now, the classical areas, like we've said, so in infants, it's classically on the face, as well as the chest and the legs and nappy area. Nappy area is a common place because, of course, it gets sweaty and the skin gets irritated by things in the nappy and the nappy. As the child gets older, more commonly back of the knees and back of the hands. Likewise, in older people, maybe also the hands, back of the neck, etc. But as I said, the triggers are multiple. Now, illnesses, also if the child has a virus, the skin will get worse. Exercise, stress, chemical irritants, weather. Now, allergy can irritate the skin, yes, and certainly some foods may irritate the skin, but less likely to be a food than something in the environment. And before I start looking at food, when I see a child with eczema, I want to know how are they managing that eczema. And the reality is that with emollients, you need to do it 3-4 times a day, in the morning before school, when they come home from school, in the evening. And thick emollients are better because they last longer on the skin than the lotions, but it may be the child doesn't like anything too thick, but then you need to do it more often. But really the point is, we'll try to prevent the itch scratch cycle, because when it starts to get itchy, the child will scratch. And when they scratch, they're causing damage to the skin, and then it gets worse. So we need to break that. So if the child is itching, if there are certain areas that are red and itchy, then the moisturizer is not enough. Then we need steroids. But in order to reduce the need for steroids, we need to be moisturizing. And emollients, we have to do it. It's a big job for parents with significant eczema all over the body, because of course all the skin can be affected. And if you use it properly, then you will reduce the need for steroids. The best ointment, parents ask me, is the one that the child will accept, the parent will apply. Absolutely. But creams and emollients are better than lotions. Oils are not so good. So find your moisturizer that you're happy with and do it often, absolutely. But when there are areas that are red or itchy, no, we don't need to look at allergy yet. Let's get the basics of treatment right. And that's when we use steroids. And they are the first line option if the skin is itchy, sore, and red. Now, we worry about steroids because there's quite a lot of misinformation out there online, but they are effective. And if we have a child that's suffering and the skin is cracked and broken down, then they are much safer than just leaving that alone. The stronger the steroid, the more effective they will be, but we use the weakest one that works. We want to break. We don't want to keep using steroids. We want to stop after a certain time. Now, I hear doctors tell parents, you must stop after 5 days, after 10 days, etc. I don't know how they know that, because when you prescribe steroids, I tell parents, I don't know how long you need to use it, but you need to use it until it's better. And if you only use it when you need to, then they are safe. Of course, you continue your moisturizing the rest of the day, but when you apply the steroid on its own, you wait half an hour before you apply the moisturizer. Now, food allergy may be a possible trigger, but there are many others. But first of all, we get the basics of treatment right. And how much steroid do you use? Well, there's this issue called the fingertip unit. If you put it on your finger like shown in the photo, that amount of steroid will be suffice for that amount of that surface area on the child's skin. So we use, so you play it on thinly, absolutely. But alpha court is very weak and is not suitable for the hands and really for most of the body, but it's okay for the face. But for stronger ones, if you're using alpha court and it's not working, then it's better to use a stronger one that works and stops the redness and itching than using a weak one that you need to keep using every day because it's not having a proper effect. There was this excellent review of steroid use in children and adults with eczema, looking at all the research over many years, and they're looking at to see, is this safe? Now, we know that adherence to using steroids is poor because parents have concerns about thinning and they are concerned about whether there's any effect on growth. But this research looked at all the data and they found there's no evidence that corticosteroids cause harm when you use it as needed for flares, only in the areas that you need it. Or you can use it sometimes just every weekend to keep it at bay. They found that the reporting of skin thinning is very uncommon, even with strong steroids. And there's very little evidence to support stunted growth. In fact, there's no evidence or impact on your hormones. The long-term safety of corticosteroids, the evidence is limited because studies looking at their use don't go back and look at the children 5-10 years later. But one large study over 5 years found very low rates of any adverse events. Now, one thing parents worry about is that the steroids may reduce skin pigmentation. But it's not the steroids. When this happens, this is eczema causing this. These pale areas on the skin are in the areas where the skin was red and dry. And that color will come back, but you need to moisturize and treat the steroid skin, treat the eczema skin so it normalizes. And then the pigment comes back. But that pigment loss has nothing to do with steroids. Now, what about eczema and food allergy? So we're going to talk about food allergy, but what about using elimination diets? So sometimes parents are advised, well, take out milk or wheat or egg in your diet and see what happens. Well, actually, there's very little evidence that they are effective in the management of eczema, but they are commonly advised. The problem when I think parents focus on food is it takes away the focus from actually how are you managing this eczema? Are you getting the basics of care right? That is moisturizing 3 or 4 times a day, avoiding soaps as much as you can, and using steroids for the red, dry areas. If you avoid foods when their child is not allergic, and allergy means when I eat the food, they get a reaction, that avoidance may lead to more allergy. And one study found that 19% of children in that study went on to become allergic to the food they were avoiding, when at the time they were avoiding, they were not allergic. This is important. We know that if children don't take food from a young age and avoid it for a long time, their risk of becoming allergic goes up. The only way of finding out whether a food triggers the eczema or not is not by a test. The way we do it is the parents come to me and say, look, I'm worried that this food is a problem because I see an association. And I say, if you see that association, even when you're moisturizing regularly, then try and avoid that food for a month. Do things get better? If after a month things are better, are they better because you're avoiding the food, or are they better because the eczema's got better anyway? Bring that food back again. Long term, a food avoidance has problems. It can lead to more allergy, plus it can lead to nutritional deficiencies. It can lead to abnormal eating behaviors. If children avoid certain foods unnecessarily, it becomes difficult to bring those back. So this 11-month-old who I saw in clinic, who is scratching a lot, not sleeping at night, how my approach would be to first ask the family, what are you doing so far? How often are you using moisturizers? Are you using steroids, and what strength? And clearly, if they are using steroids and there's still a problem, then they may need something a bit stronger. I would look about whether there's anything about infection, and obviously talk about safety of steroids, etc. Regarding allergy, I would ask, was there any relationship to the eczema getting worse when they introduced the food, and maybe do a food diary, but I wouldn't do a blood test. And this is important. So eczema, basics of care, steroids are safe. There are alternatives to steroids that are coming, and I'm not talking about that today, but steroids are safe, and we would think about alternatives if we're needing too much of them or they're not having an effect if being used properly. But are they being used properly? Okay, another child. So this is a baby who's crying, reflux, seems to be in pain, has dry skin. The parents want to know, is it milk allergy? Is there a test? What is it the formula? So this is one child where we may think about milk allergy or food allergy, crying a lot, a baby. This is another type of child, a 6-year-old, ate peanut for the first time, developed rash a few hours later. Doctor is advising all nuts, but is this peanut allergy? So what are the clues that tell us whether a child is allergic or not to something? So there are two types of food allergy. There's the immediate type or the delayed type. So this is the one that we are more worried about, because this is the one that can lead to more severe reactions. Now, the immediate type, one of the key things is that the reaction happens quickly. 30 minutes majority, within the hour. And that reaction is swelling, rash, hives, itchy skin, face, body, etc. But it happens quickly. So if a parent comes to me and says, my child developed a rash 4 hours after eating peanut, peanut's not the problem. And this rash may lead to anaphylaxis, more severe reaction, causing problems with breathing, etc. But again, quickly, within the hour. Now, this type of allergy we have a test for. There's a skin prick test or a blood test. It must happen every time that food is eaten. So a child can't react to a food 1 week and then the following week they don't. And then the rash is gone by the next day. So we are seeing a lot of rashes at the moment, itchy rashes that are coming and going, lasting a few days, even a week. That is not food allergy, because they appears quickly after food and it's gone the next day. So this is the type of rash we see. So bumpy, itchy, red, like this on the body. This is urticaria. And this may be food allergy, but if parents have this rash and they are worried about food, then my question is, what was eaten just before this rash appeared? What was in the previous hour? And if it happens, then what's useful before you see a doctor is to make a note what was eaten. Look at the ingredients. Ask the restaurant, ask the hotel, sorry, this meal that my daughter seems to maybe reacted to, what was in the ingredients? Because we need to know that. Because we can't do a random test to find the answer. Because tests on their own are not helpful. We need to match it with the history. And in the face, you may get swelling around the eyes. But again, if it's food, it's happening within the hour, quickly. Now, the delayed type of allergy. So this is that 4-month-old baby, maybe, who's having tummy issues, crying, reflux. Now, these are symptoms that occur hours after eating the food, maybe even the next day. Classically, the symptoms are going to be abdominal symptoms. So colic, reflux, change in the poos, bloody poos, mucousy poos. The child may be unhappy eating the food. The child may have eczema. Now, food triggering eczema may be the case, but it's happening later on. It's not happening necessarily quickly. These never go on to have anaphylaxis. They don't have severe reactions, but the child may be miserable and suffering. The key thing here is there's no test for this type of allergy, this delayed type. There's only test for the immediate type. And an intolerance test is a bad test, and we'll talk about that. And the main foods that cause these problems are going to be foods that are in the diet repeatedly: dairy, egg, wheat, soya. but they are difficult to diagnose compared to the immediate ones because you don't have that clear association of eating and then reacting like you do with the immediate. So how do we diagnose delayed ones? Well, were the problems started when a new food was introduced? So maybe the child was breastfed, went on to formula, parents are noticing a change in the child on formula, they're seeing these problems. Maybe after weaning was introduced either egg or milk regularly, dairy, and we noticed a problem. Family history of allergy may be a clue. If the child has eczema, that may be a clue too. But of course, you know, a baby that's got reflux and crying and colic, there are some babies that are just very difficult and they have bad colic and there's no necessarily any answer and it's not necessarily allergy. And it can be hard to know because there's no test, like we said. Now, but it may be we suspect. So certainly if a child goes on to formula and there's a problem, that's a big clue. So then we might go on to avoiding that food that we're suspecting, maybe changing the formula to a milk allergy formula, and then see if the child gets better. Now, if the child is better, having avoided the food, the question then is, have they got better because we've avoided it, or have they got better because colic reflux gets better? So then we bring back the food that we avoided to see the problem come back. Now, if the child developed symptoms when they introduced a formula that previously mum was breastfeeding and was having dairy and there was no problem, then there's no reason for mum to avoid dairy in her diet. In fact, the amount of dairy milk protein in breast milk is very, very small compared to the concentration in formula. And I rarely tell mums to avoid dairy unless there's a problem while the mum is breastfeeding only. So it can be hard to know, as I said. So, but the key things would be really any past history, family history, dietary change. And then if the child has reflux or the child has eczema and we're treating the eczema appropriately, we're treating the reflux, but it's carrying on, then we may think about food. But it's all about getting the basics of treatment right. Now, itchy rash, sudden onset, lots of things cause itchy rash. Cold water, viral infections. We're seeing a lot of children with viral infections who prior to the rash appearing had a bit of a runny nose and a cough, and then they developed an itchy rash that lasted a few days. And it's likely to be a virus, particularly if they've never had it before, and particularly if nothing new in the environment or in the diet prior to that rash appearing. Penicillin, commonly diagnosed when children get a rash on penicillin, but we know that over 90% of children and adults who think they are allergic to penicillin are not allergic. And the scenario of them getting a rash when on it is in fact caused by the virus that made them go on penicillin because they had a fever and a cough, and that rash caused a fever. So if you have a child where the diagnosis of penicillin allergy is not clear, in the clinic, we rule it out by giving one dose in the clinic and watching for an hour. Children can get an itchy rash if the fish was off. If the food was a bit dodgy, they may get an itchy rash. Sometimes we don't know why there's an itchy rash. And eczema, of course, is itchy rash too, and that's a skin problem. But allergy testing, looking for the answer, is not a good idea, in my opinion. The problem with allergy testing, and this is IgE testing or skin prick testing, is that there is no test that tells you you are allergic. Because a positive test does not mean you are allergic. Now, the way I diagnose allergy, when I do a test, is because the parents come to me and say, we think this food's a problem because this happened after eating this food. And if that problem sounds like allergy, then absolutely, I test that food. And if the test is positive and the history is positive, so we have both things, they come together, we diagnose food allergy. Because food allergy means I react when I eat it. It doesn't mean the test is positive. But what happens when you do lots of tests is you will get foods that are positive, but the child is eating. And the problem here is that doctors are telling parents to now avoid that food. And that is wrong. Why are they avoiding it? If they already were eating it and there was no reaction, it's fine to eat it. And if we overdiagnose food allergy, which what happens when we do these panels, then we wrongly tell parents to avoid food, then we have more allergy developing, carnage, disaster for the parents, food avoidance, etc. So I don't do any panels regarding food allergy testing. Now I do them for asthma, for things in the environment, because if you overdiagnose pollen allergy, that's not a problem. But if you overdiagnose peanut allergy and the parents think my child's now got a peanut allergy when they haven't, that is life-changing. As I'm sure parents who may be on here with food allergy know, when you have a definite food allergy, that impacts on your life a huge amount. So let's make sure we don't increase the impact unnecessarily by overdiagnosing foods. And this is what I'm talking about. So this is a child who came to see me that had this panel test done by the previous doctor. And they came to see me having reacted to egg. And the test for egg, we can see, is very high. So yes, they are allergic to egg. But look here, milk, a little bit, wheat, soya, peanut, hazelnut. And the doctor suddenly told this parent to avoid all these foods. Now, the patient was already having milk and wheat, so I told them to bring it back, absolutely. This patient had never had peanut before, but his parent was now scared to give. But we need to give it. So I said to the parent, come to clinic, let's give it, we can see what happens. Nothing happened, the child is not allergic to peanut. But this child should never have been tested for peanut in the first place. But doctors do these panels in the hope they're being helpful, but actually are causing more problems. Now, just to look at the number here, it is high for egg. And if we did a skin test, if it's very high, the size or the level of the result, the bigger it is, it doesn't mean the worse the reaction. All it means is the bigger it is, the more likely we have allergy here and not sensitization, which means a child who can eat a food but has a positive test. But absolutely, so if you have a child who's been told to avoid foods based on a test when they've never eaten them, they may not be allergic. The only way of knowing is to give the food. And if you are scared to give it, see your doctor to try and facilitate that. And I do it in the clinic. In the clinic, we do skin testing, very useful, much easier. In my clinic, there's no charge for that. It's just a consultation. The vials, they cost so little money. I feel we shouldn't be charging for this test. But the problem is if the child is on antihistamines, we can't do the test because it may influence the result. So when do I do the test? So I do it if we suspect a food allergy from the history and we test that food. Now, if the child has a nut allergy, like peanut, and they're scared to try other nuts, then I may do other nuts. But the key thing here is if the test is negative, I tell the parents to go ahead and give it. If the test is a bit positive, it doesn't mean they are allergic, but maybe we try that nut in the clinic. Because a negative test is pretty good. It's about 95%, but not 100%. I do this test also for asthma. So if a child has asthma and they have a pet at home or they're worried about dust mite, then we can do the test because the blood test is quite expensive. I may do the test if the child has a persistent itchy runny nose, they're worried about allergy. Rarely I do it in eczema really, unless there's a story. Now, of course, children with eczema, they may have these quick reactions to food and they may be allergic to a food, but we're basing the allergy diagnosis on the story of them quick reaction, not on their skin. But as I said, we do free allergy tests, skin prick testing in the clinic. So if your insurance doesn't cover you, we do it in the clinic just as part of the consultation. Now, what about alternative tests? So very common. So this is Vega testing. So here we look for electrical impulses. And this is Vega testing where the patient holds the food with their arm out, and if somebody presses down and it gives way, you're deemed to be allergic. Now think about this. How is this even possible? We know what allergy is. We know the genetics. We know the immunology. It's IgE related, binding to cells. When it comes into contact with the food protein, you get rash and swelling. This, I mean, is dangerous really for this to be done, and for parents to be told wrongly or rightly, you are allergic based on this power in the shoulder. I understand parents are desperate for answers, but honestly, follow the science, follow the advice from allergy bodies. And then lastly, this test, the food print test, very common test. And it's one that parents like, because of course they get all the foods and they have an answer. Great, I know what to avoid. But the problem is the foods that are coming up to be avoided, because the IgG is high, are the ones that they're eating regularly. Making IgG is normal. That's your immune system working normally. Foreign protein, antibody made. If you're eating a lot of that food, you make a lot of antibodies. And in fact, IgG antibody is related to tolerance, not allergy. So when you get this result and you're told to avoid all these foods, it's so wrong. It's not accurate. And I see children who've been told to avoid all these foods. It's hell for parents trying to avoid all these foods. And the children, I saw a child who had not gained weight for 6 months. Now, on this panel, there may be foods that the child is intolerant to, because food intolerances exist, absolutely. I'm not denying that, but this is not how you test it. So if I see a child who's had this test and the parents are avoiding 10 foods and the child is better, great, the child is better, but the child is suffering avoiding all these foods. I tell the parents, start bringing the foods back. And if the child is intolerant to one of these foods that they bring back, then the problem should come back. And that's how we diagnose intolerance. We're seeing the problem come back. But if the food comes back in the diet and they're fine, then we ruled out intolerance. And that's the only way of diagnosing food intolerance. You suspect a food from the history, food diary, you remove it, the child gets better. Have they got better because you removed it? You bring it back, the problem gets worse. So these alternative tests are really, to be avoided at all costs. They're very expensive. Sadly, many doctors are doing it. Sadly, some allergy doctors are still doing it. And absolutely, it shouldn't be done. Because IgG is protective. It's not a sign of intolerance. And as I said, the impact of food allergy diagnosis is huge. A lot longer to shop, a lot more expensive. Quality of life scores for parents who have a child with a food allergy is worse than type 1 diabetes. There's a risk of compromised nutrition. So we really need to be careful. So treatment of food allergies. So first of all, proper diagnosis. So you suspect a food that your child is allergic to. Okay, are they allergic to that food? Let's do a test. If the test is positive to the history, we have an answer. If the history is vague or the test is negative, then maybe they're not allergic. And in that situation, I would do a challenge. The only way of knowing for sure is to try the food again. Now, if the parents are scared to try the food again at home, absolutely, we do it in the clinic. But after a test first and making sure it's negative, and after I look at the history. The treatment is avoidance only, but we want to only avoid the foods that we are allergic to. And then, of course, we need to be prepared and know what to do if the child has another reaction. And there are two types of reactions, a mild or severe reaction. So mild reaction, what's a mild reaction? So this is maybe some swelling of the lips, of the eyes, itchy mouth, some itchy rash, but the child is talking to you, is not too distressed, breathing is fine, behavior is normal. So in that situation, I give antihistamine and stay with the child and monitor, or bring the child to your doctor if you're worried. but we don't give adrenaline for mild reactions. Now, there are some doctors who would do that, and there's a very good doctor here who does do that in Dubai, and he's following the US protocol for some doctors in the US. But in Europe and Britain, we don't give the pen for all children. And antihistamine is safe. It won't mask a reaction. But absolutely, we monitor the child. And if at any point the child deteriorates, then we may need a pen. What are we looking for? So, anaphylaxis signs. Look at is there any problem with the airway, the throat, any cough, change in voice? Is the child saying, I can't swallow, irritated by the throat, the tongue is swollen? Is there a problem with breathing? Any noise to the breathing, any change in the breathing whatsoever, or sudden coughing, persistent? And is the child pale or dizzy or floppy? Then anything like this, then we lie the child flat, or if the breathing is difficult, allow the child to sit up on the floor and give your EpiPen without any delay before anything else, and then call 999, absolutely. And stay with the child until the ambulance arrives. Don't make the child stand up. If the child deteriorates, of course, you may need to give CPR, but hey, this is very rare. But if there's no improvement with the first dose of adrenaline after 5 minutes, then you give a second dose if you have a second dose available. And if the pen you reach for has expired, it's safe to give that pen. No matter how expired it is, it's much safer to give that pen than do nothing. But of course, try and get your pen, replace them when you can. An EpiPen, you should all know how to use your EpiPen. Glue off in the thigh, hold it firmly for 5 to 10 seconds, and then remove the pen. Jext is also available and a very similar technique, but rather than a swing and push, it's push down, but very similar. Make sure whatever pen you have, you're happy to know how to use, speak to your doctor. They are very good videos on YouTube for these pens. When it comes to bad reactions, where are they happening? Where's the high risk situation? So parents worry about school, but in fact, school, it's a very unlikely low risk of bad reactions happening at school. The most common areas for bad reactions are in a restaurant or at a friend or relative's house where they're not aware what's going on, where you're not in control. But the risk of severe reactions, fatal reactions, is very, very small. It's, the number of children that die from food allergy, there's far more children dying on the roads. So obviously parents worry about bad reactions, and we need to be preparing parents in knowing what they need to avoid and knowing what to do when a reaction happens and having an EpiPen if they need to. But the risk of severe reaction is very small. And what I tell parents, in fact, the risk of driving to the clinic is much higher than of a severe reaction. And the vast, vast majority of anaphylaxis does not lead to a severe reaction. But let's not negate the risk involved and make sure you are prepared in knowing what to avoid and knowing how to manage the reaction. And it's vital to always carry your EpiPen. But sports with friends, but many teenagers particularly don't always carry it. So like on the sports day in this study, only half people carry it. When they go with friends, less than 60%. When they go to a friend's house, 60%. Really important to be carrying it, but we know that often teenagers forget. So when you have a reaction, remember the risk of a fatal reaction is very, very rare, but appropriately manage the reaction. Know what to do, carry your pens at all times, know when to give the pen and give it. If there's any doubt, give the pen, absolutely. Now, severe reactions, they only happen if you actually eat the food. Severe reactions are unheard of from touching or being nearby. Now, there are some high-profile cases of children and adults having reactions on the plane. But this has been looked at extensively, and peanut powder is not in the environment, it's not going round, and it's a very controversial topic. And there's many people, high profile people, who for me are stoking fear about this, because the reality is that these food proteins are not in the air. And there's a recent case in the newspapers of a patient passing out and needing adrenaline because somebody ate peanuts, I think some rows away on the plane. That for me is a panic attack. Absolutely, it must be, because it just doesn't happen. We don't see this in restaurants. When you're in a restaurant, someone's eating peanuts away. Why would the planes be different? But on the plane, you can reduce the risk by cleaning your local area, taking your own food on board, and of course, carrying your pens and antihistamine. We're not saying reactions don't happen on planes, but severe reactions absolutely happen if you eat the food. And of course, know how to use your pen. Now, what about some other reactions? So younger child with weaning, okay? Mum's given this child scrambled egg and had a bit of rash on the face. And the question I ask here is, did the child enjoy eating it? And the parents say, yes, he loved it. Now, if the child is enjoying eating the food, that probably is not allergy, because allergy causes itchy mouth. Now, a young child can't tell you that their mouth is itchy, but they can tell you by their response to not wanting to eat it. They reject it. And this rash disappears very quickly. And this is what you see, this rash on the face. Is it allergy? No, there's no swelling. The child enjoys eating it. It goes away. This is a rash from contact. Children are messy eaters. It gets all over the face. And if the rash is where the food's been in contact, then probably not allergy. Now, we could do an allergy test, and here we did a blood test, very low, very slightly high. The story's not right, the blood test is low. I say to the parents, come back to clinic, let's try again. Let's put some cream on the face before eating, and then we'll try. Did anything appear? And 9 times out of 10, they manage it fine. And we rule out allergy. That's life-changing. Egg is a big product. And if we can rule out allergy, half of my time is ruling out allergy as well as diagnosing allergy. What about siblings? So you have a 2-year-old here who's got a 9-year-old brother who's got peanut anaphylaxis. And the mum wants to know, does the 2-year-old have peanut allergy? And now the mum is avoiding walnuts because she's scared, and she comes for a test. But there is no test, as we've said. Great study in 2016 looked at over 1,000 children who had a sibling with food allergy. They all had a test and they all had a challenge. Now, 33% had a negative test and no symptoms when they were given the food, so they weren't allergic, but only 33% had a negative test. Half the children had a positive test, but when they were given the food, there were no symptoms, so they were not allergic. But a positive test means half of the children are being wrongly diagnosed being allergic if we rely only on the test. So screening is unhelpful. So what I do here, I say to the parents, let's try if you're scared. Come to clinic, sit downstairs in the canteen, in the hospital, whatever, let's try and see. And if the child is fine, then you know the child's not allergic, and continue giving that food in the child's diet safely when the sibling is not around. But if you avoid that food in a child who has a sibling with peanut allergy, long-term avoidance is going to increase the risk of that child becoming allergic for real. And surely our job in allergy is to try and prevent allergy as much as we can, as well as treating it. So lots of scenarios there. We'll take questions at the end on food allergy. So I don't know what's how this line is on here. Okay, lastly, let's talk about asthma and the chest. So 6-year-old boy who's coughing a lot for 3 months. Mum thinks he's wheezy. So 6-year-old boy, 3-year-old boy, 2-year-old child, coughing a lot. Seeing lots of children with coughing. So either we have a 2-year-old child who's coughing, or maybe an older child who may have asthma as well, and the parents are worried, is it asthma? Any tests we can do. What about the future? Now, if you have a child with asthma, then absolutely we need to be treating asthma seriously. So there's a couple of situations in the UK here. This is a child here on the right. Doctors missed 11 chances to treat the chess champion before he died of chronic asthma. This is a child here on the left, schoolgirl, who died of an asthma attack, was making regular trips to A&E and running out of medication, but was never seen by a specialist. Now, asthma, if a child has asthma, is a serious condition because if it's not treated properly, the child can deteriorate, and absolutely some children die from asthma. Of course, it's rare, but even if they don't die, it's debilitating. So this child on the left was going to A&E regularly with her chest. And the problem is, if you go to your A&E and go to your doctor, you get medication for that asthma attack, the child gets better. You need a doctor to be looking into why is this happening rather than just giving medicine for each attack. Why is the child having attacks? And by looking at that, we can prevent these serious scenarios. Now, the question you have to ask yourself in a child that has asthma is, what's my control like? And what we want children who have asthma to be like is this. Do we want them to be in the green here? We want them to have good control of their symptoms. So what does good control of your asthma mean? It means symptoms during the day, 2 or less times a week. It means no limitation of activities. Children with asthma should be doing all their sports as normal. They should not be having any nighttime symptoms. They should not be needing their Ventolin more than twice a week. And if they have a breathing test, their lung function is normal. So this is what we want good control to be. And this is what we should be aiming for. And if you have a child with asthma at home, they should be like this. And if they're not like this, then they need some input. We need to adjust their medication. We need to find out why are they not like that. If you're partly controlled, where you're having limitation, having nighttime symptoms, and you're needing your Ventolin more often, then you're much more likely to suddenly have an attack. And the attack brings on trips to hospital, maybe admission, the worry, you've got the child that's breathless, time off work, time off school, etc. We need to be keeping the child over here on the right in the controlled area. So the question is, if a child has asthma and they're not well controlled, these are the things I need to be thinking about. Are you on a preventer? And if you are on a preventer, which is normally a steroid, are you taking it? You need to take it twice a day, every day for it to work. Is the child taking it on their own? Come on, you can't rely on children to take their medicine on their own. Is the asthma better in the summer? So they stop taking their medication, and then come school time, it gets worse again. Now it gets worse again because they go to school. It's not allergy. When things get worse, we're after summertime, parents think it's the weather back from England, allergy, etc. It's not. They go back to school, they're in contact with other children, they get a virus. A virus is a big trigger for your asthma. Are they not taking their preventer because parents are worried about steroids? Again, you need to speak to your doctor about that, but they are very safe and they save lives. Steroids mean good control for asthma for many, and that means a quality of life that's good for the child regarding exercise, etc. But they only work if you take them as prescribed, but also as long as you take them properly. You need to use a spacer. If you're on an inhaler, like a Ventolin or the orange one, don't put it in the mouth. You try and blow one. It comes out so quickly. If it's in the mouth, it's going to hit the back of the throat. You need to use a spacer so you have more control taking your breaths. And I will review the technique of children who I see. And there's this great website, asthma.org.uk, with videos about inhalers. So absolutely, are you taking your preventer? A bit like eczema, are you taking your moisturizer every day? You know, the care of children with allergy is similar in the sense that you need to take your medicines all the time. And this is a great graph of showing how you need a spacer with an inhaler. So you can see here on the left, it's in the mouth, and it's just, and you blow it in and you see where the medicine is. It's in the mouth, there's very little, and a bit in the stomach, but very little in the lungs. But when you use a spacer, its majority is in the lungs. You must use a spacer. Now, what about using nebulizers? What's best, a nebulizer or a spacer? Now, it's always a shock for people from England and expats, because where in England, for example, nobody has nebulizers, but everybody has nebulizers here, or majority do. But and the belief that nebulizers are better for asthma is just not true. And actually, the Ventolin is better to be taken with a spacer. And there was a study looking at using nebulizer and spacer in the ER, and children went home quicker when they were given a spacer rather than nebulizer. Yeah, nebulizer is a bigger dose, but it's all over. It comes all around here. And what a faff nebulizers are. Plugging it in, cleaning it, you can't use it. Speak to your doctor. Spacers are much better. And what about managing an attack? So this is what we do, okay? Sit them up straight, keep calm. Child is wheezing, breathless, we're worried. Use a spacer. You give a couple of puffs every few minutes, up to 10 puffs. Now, if after 10 puffs, they are feeling better, wait a bit, monitor them. You need to be helping them for 2 or 3 hours. That should last for 2 or 3 hours. They may not need 10 puffs. It may be after 6 puffs. But if you give 10 puffs and they're still breathless, they're still wheezy, there's still a problem, then you need to call 999. If a child does not respond to 10 puffs, you need to get them to hospital. Now, while you're getting them to hospital, you can give more puffs, but you don't then keep them at home. That's the point. Because if you give them too much and you keep them at home, then there's a risk they may deteriorate much more. Allergy and asthma, I ask about this. We may do some testing. So again, summer, you know, do the child have hay fever in the summer? 80% of asthmatics also have hay fever, and we need to be treating the hay fever. Absolutely. Are there pets at home? So, you know, is that maybe triggering their asthma? Does the child have an itchy nose, a runny nose, showing allergic rhinitis, hay fever? Does the itchy nose get better when the child is away from home on holiday, etc.? Now, your child may have a hyperallergenic pet, but in fact, there's no such thing as a hyperallergenic pet. What you are allergic to in a dog and cat is the proteins in the saliva, in the urine, in the gland secretions, etc., which they all have, of course. But if the animal sheds hair, that may hang around longer and may cause more of a problem. But those ones that don't shed hair can still be a problem. But let's do a test. I don't agree that doctors may say to you, get rid of the pet without doing a test. We can do a test. Look at dog, cat IgE to see if they are allergic. Dust mites. Is there a problem in the morning, coughing at night, sneezing, blocked nose overnight? Dust mites live in the pillow and the mattress. And there are covers that we can get that trap the poo in. So what we are allergic to is not dust. These sandstorms, your child is not allergic to sand or the storms. The dust is from the skin, is dead skin cells. But what you're allergic to, the mites that live in the soft furnishings, pillow, mattress, sofa, carpets, they eat the dust, and what they poop, that's what you're allergic to. But absolutely, we do a test. Parents are worried about allergy and cough and runny nose. We do a test to find out. So we've only spoken briefly about asthma because I wanted to speak more about food allergy, but the key things are take it seriously. Know what to do in an acute attack. And if you don't know what to do, speak to your doctor to give you a plan. go online. This website, asthma.org.uk, is very good. A child with asthma should have a normal life, and only a specialist pulmonologist should tell you your child can't. And if the doctor can't help, seek specialist advice. And read about it and empower yourself. I think doctors don't treat asthma as well as they should do. And if you're worried about your child and you see your child suffering, then do seek specialist advice. Now, the last thing I'm going to talk about is food and weaning for allergy. So we've got a 6-month-old baby, dry skin. It's breast and bottle fed. Mum wants to wean, but she's not sure what to give. And she asked me, can I give peanut? So what's the advice now regarding allergy and weaning and pregnancy? So first of all, pregnancy advice. Well, the advice currently is that there is no need to avoid any foods during pregnancy, including peanuts. And the reason for that is that there is no evidence to show that avoiding that food reduces the risk of allergy. In fact, there may be evidence to say that if you eat it during the pregnancy, that is protective. But we're not at the stage to be saying that categorically, but we are saying at least there's no reason to avoid. So, you know, being pregnant is wonderful, but it's hard work, all these motions going in. So, you know, as far as I'm concerned, if the mother wants to eat a certain food, let her eat, it's fine. Having some oily fish in the diet, there's some evidence that may reduce eczema food allergy in early life, but only eat 2 portions a week. It's not clear that rooting probiotics prevents allergy. The key thing during pregnancy really is eat a balanced, healthy diet. Follow the advice about vitamin D and folic acid supplementation, but eat a balanced, healthy diet during pregnancy, involve all the food groups, and that's doing the best for your child regarding allergy, but general growth as well, of course. Now, what about giving solid foods? Now, in 2000, the year 2000, the American Academy of Pediatrics advised avoid cow's milk until 1 year, avoid egg until 2 years, avoid nuts until 3 years. But this was changed in 2008 because there was no evidence to support this. In 2018, we are now saying, let's actively introduce these foods. So when can we introduce solid food? So the first thing is when we give solid food really is when you're ready, when you want to. The World Health Organization says wait till 6 months for breastfed babies. And if you want to do that, that's fine. But at 6 months, you need to start. But if you want to wait till then, it's fine. But if you want to start before then, no more than 4 months, you can do. And you may want to because maybe the baby's ready. How do we know the baby's ready? The baby can sit relatively unaided in a high chair, will need the support on the back, but has got a steady head that can eat and is not flopping down forward. The babies may be showing some interest. They're reaching out, they're looking at you when you're eating. And then there's loss of the tongue thrust reflex. You try a bit of food, bit of tasting, and the baby enjoys it rather than just reflex pushing it out. But this decision about when to start, absolutely, I leave to the parents. I don't encourage early weaning necessarily from 4 months, but I say you can do if you want to, but you must start at 6 months. Now, when we start, we normally talk about small amounts of pureed vegetables and fruits, but very quickly, you can start egg, cow's milk, peanut, weeds, wheat, seeds, fish, as long as in a form that they can have. They can't have a peanut, but they can have peanut butter. But very quickly, you can start this. There was this study, the LEAP, which you may have heard about, looking at introducing peanuts at 4 months or after 5 years, or from 4 months to 11 months or after 5 years. And those that were introduced at 5 years had far more peanut allergy than those that were given it under 1 year. And there was an EAT study where children were weaned at 3 or 6 months. Now, it was safe to give them at 3 months and they still breastfed normally, but there wasn't much evidence to support less allergy if you're giving it too early. So waiting till 6 months is perfectly fine, but very quickly build these foods up. So in summary, not before 4 months. When the baby's ready, give the food, start with vegetables and fruits, no added salt or sugar. And once eating those, start bringing in egg, nuts, dairy, etc. There's no need to do a test. Now, they may have a reaction at home, like any child. And obviously, if they do, make a note, see your doctor, arrange a test. It could be a contact reaction, let's see. But have fun. Anaphylaxis in infants is extremely rare. And it's safe to start weaning. Now, there's a choking and all that element, but regarding allergy, severe reactions, extremely rare. You won't have read anywhere online about a young baby having a bad reaction. These are the ones we read about in older children and teenagers. Okay, we've covered quite a lot this evening. We've looked at food allergy, we've touched on asthma, but I wanted to speak mainly about food allergy and asthma. Now, if anybody would like to ask any questions, then they are most welcome to. Fatima.
Yes, doctor. One question have popped up.
So we have a question here. First question, how long does it take for a reaction to start after eating a food? So again, the question is what type of reaction? So if we're talking about an IgE mediated reaction, then it happens within the hour. Normally a bit quicker than that, but it doesn't happen hours later. So this is the key thing in taking a history. When parents come to me saying that they are worried my child has a food allergy, I ask them, tell me what happened. Eating it, when did the reaction appear? So it must be within the hour. Normally quicker than that. If it's longer, then it's not going to be IgE mediated. Now, delayed reactions happen, but that's more tummy problems and eczema flare-up, not the quick reactions we worry about, the quick reactions we have a test for. That must happen within the hour. Now, next question. If somebody whose reactions have been mild in the past for a food allergy may suddenly experience severe reactions that could be deadly? Yes, very good question. I didn't mention this. This is one of the allergy myths that are spread out there, that reactions get worse each time. This is not true. It's not the case that reaction will get worse every time you have a reaction. Now, reactions can get worse, absolutely, but it's not a foregone conclusion. Now, what may make a reaction worse? So, if the child had a reaction, mild reaction to maybe touching it or having a little bit on the lip, but then next time ate a lot of the food, then it may get worse because suddenly the child is exposed to more food. There seems to be some evidence that reactions to food may be worse if the child or patient who ate the food was sleep deprived or had just done some exercise, or if it's an adult, was drunk. There are other things going on, but as a routine, it doesn't get worse. So if a child perhaps ate a big portion of food that had lots of peanut in there and had a mild reaction, we can safely say this child has a mild allergy. And that we need to avoid the peanut, absolutely. But if the child had an accidental exposure of a lot less, then it's likely the reaction would be a lot less. So it's not the case they get worse every time. But that is a myth that's reported out there, and it causes undue anxiety for parents. Okay, if you have any other question on that, then do respond to that. I saw a doctor prescribe ipratropium to wheezy babies without Ventolin. Is this okay? So, okay, wheezy babies. So wheezy babies may not necessarily have asthma. So if the child has asthma, if that baby has asthma, which would be unusual, and what age was the child? But if you have asthma, then you give Ventolin. You don't take ipratropium for an asthma attack. You have Ventolin at home. And we need to think about, has the baby got asthma? Why is the child having attacks, etc. Now, some babies under 1 that get wheezy, that's called bronchiolitis, and we used to give ipratropium as part of their treatment. Here in Dubai, babies with cough and maybe wheezing, but cough, get so many nebulizers. They get Ventolin, they get ipratropium, they get Pulmicort. And, it drives me mad, to be honest with you. In the UK, in England, no one has nebulizers, and they have the same illnesses. These nebulizers should be given because the child has a breathing problem. And if the child has a breathing problem, then they need to get seen, etc. I see so many children who are coughing from a virus. I ask them, how is the breathing? How's the drinking? Parents say, oh no, he's fine. When he's not coughing, he's active, he's running around, there's no problem. They don't need Ventolin, Pulmicort, ipratropium. These are for breathing problems because there's respiratory distress. These nebulizers don't help the mucus in the nose, stuffy nose, coughing throat, mucus, etc. And they have their side effects. Ventolin has side effects. It puts your heart rate up. You don't feel well with it. So, I mean, this child that's wheezy, this baby, obviously difficult to be sure, but generally Ventolin would be the first line treatment. Yes. If my child has outgrown a food allergy, is it okay to try a small amount of that food? Well, absolutely. The definition of being outgrowing a food allergy is that they are no longer food allergic. They're no longer allergic to that food. So if they're no longer allergic to that food, then they should be tolerating it fine. I guess the question is, do you think, if you have a child, are you sure they have outgrown it or not? Are you thinking they have? And if you're not sure, then is the right thing to do to try at home? Maybe not. That depends on previous reactions and all those things. So generally in my clinic, if we think a child has outgrown a food allergy, how do we know? And obviously the majority of children who are allergic to egg and dairy indeed do outgrow their allergy. But how do we know for sure? Then maybe they come to me and say, oh yes, my child had a bit of peanut last week by mistake, he seemed fine. Well, if we're sure he ate it and he's fine, then he's outgrown it, give it again. But any doubt, we may do a challenge in the clinic. We may do an allergy test if they were allergic before, and if the level of either the skin test or the blood test has come down a lot, that may be a sign of them outgrowing it. But the only way we're going to know is to give it. And if we challenge them in the clinic and they've tolerated it and means they've outgrown it, then they can eat it at home. Remember, food allergy is very simple. If you are allergic to a food, you must react every time. You can't react 1 week and not another week. That means you're not allergic to that food. So again, when parents come to me and say, oh, I think my child's allergic to peanut. Why? Well, he did eat it last week, but this week he ate it and had a rash a few hours later. Well, you had it last week. Very unlikely. A few hours later, I don't think so. Let's give it again. So absolutely, you can give it if they've outgrown it, yes. But have they really outgrown it? Can a common fever or viral fever flare up eczema? Absolutely, yes. It's a cause for eczema flare-up. 2 things. 1, general unwell of the baby. The virus may trigger eczema, immune system being overexcited by the virus, etc., causing flare-up. But also, if they've got a fever, viral fever, they're going to be sweating. And if they're sweating, that's going to trigger the eczema because sweat is a trigger for your eczema. So if you have a child with eczema and they have a fever, make sure you're moisturizing plenty. Make sure you're giving them regular hydrating baths, not much soap, wash that sweat off, moisturize afterwards. And if they have a flare-up and they're itchy and red, then do use the steroid cream. It's fine to use the steroid cream even if they have a fever or a viral fever. We're giving steroids here on the skin. It's not the same as taking it by mouth. But of course, we do give oral steroids if a child has an asthma attack from the virus. So very safe. That's my hypoallergenic dog out there. How much of a food allergen does it take to cause a reaction? Now, very good question. So it depends on the child, essentially. But we know, for example, for peanuts, that they did studies, the vast majority need to have a certain amount. I think it's 1 milligram to cause a reaction. So again, you know, this anxiety about food being nearby, in the air, such tiny amounts. Yes, you may get some reaction on the face. Yes, children with asthma may get some coughing and wheezing. For example, milk that's boiled if they're allergic to milk. But this is child with asthma having an asthma attack. But food allergic reactions, you have to eat it really to have a severe reaction. And normally they have to eat a reasonable amount, but it will depend on the child. So what can be helpful is doing challenges on patients and children whereby parents are not sure how much the child can tolerate. And actually, if they discover that the child is reacting to peanut, but only after eating half a teaspoonful, rather than reacting to a small amount, that sort of challenge in the clinic is reassuring for the parent, because they now find, good, I know not to give peanut, but I now realize that my child can tolerate a very small amount. So if there's something in the food by mistake or something nearby, my child will probably be okay. So we can do that, but we can't work out how much from the test. Again, it's all back to the story. And if we don't know, of course, we just have to avoid, and then over time you may find out. Any other questions? Some great questions there. Yes, one more coming up here. Can my child outgrow their food allergy or be completely cured? Okay, so absolutely some children will outgrow their food allergy. The most common foods that children outgrow are egg and milk, and by teenager years, 80–90% have outgrown it, absolutely. But some carry on. Nut allergy, we believe around 20% outgrow it. Now, you've probably read about immunotherapy. Immunotherapy for food allergy is basically giving small amounts of the food protein regularly in a controlled way to get to a point where the child now can tolerate and not react to certain amounts of that protein. Is it a cure? No, because we don't know the long-term future. A cure means it doesn't come back. It's never really gone away. It may come back, and the child is dependent on eating that food regularly for a long time. Now, immunotherapy for children, if it's given early to preschoolers when we first find the diagnosis, it's more effective than if we give it to teenagers, etc. And I don't offer this service, but there is a doctor in Abu Dhabi at SNO and Allergy Clinic, Dr. Carr, C-A-R-R, who offers this service. And if your child is allergic to maybe like hazelnut or walnut, and they're not allergic to other things, and you want them to be reverse this allergy, I would look at that and meet him. But the treatment with immunotherapy does have its risks. You are giving a food they are allergic to, they are risking a risk of reactions, etc. But the risk is lower for preschool children than for teenagers. Will this treatment come to UAE for teenagers, this medicine that's been formulated and given now in the US and the UK? Maybe, but it's very work intensive. It comes with risks. And in the current climate of doctors feeling, you know, from the authorities, etc., it'd be interesting to see if it comes, when it comes, will insurance pay for it, pay for all the appointments, will they deem it too risky, etc. I think the key thing now, really, with food allergy is knowing what you are allergic to accurately, and don't rely on tests, do challenges and avoid it, and be prepared for accidental reactions carrying your pens and antihistamine. But if you get it early, at the 1, 2, 3 years of age, then maybe just using food protein rather than all this expensive medication, there is a possibility to help you there. My kid is having eczema, is also having dry and flaky scalp too. Is it dandruff or related to eczema? How to cure it? So, of course, the scalp is the skin like it's skin like everywhere else. And if your child has eczema, then the dry, flaky scalp is probably eczema as well. So the treatment is using a moisturizer and something maybe less thick, much easier if you've got hair like mine, obviously, but hopefully your child has a bit more than me. So you can use a regular moisturizer. You can use a steroid if it's itchy to reduce the redness, and use a special shampoo, and not every day, but absolutely there are products out there for eczema to use. But really you treat the scalp like you treat your normal skin, but the type of cream you might use for the steroid or the moisturizer is maybe a lotion, because it's absorbed much easier. Thick cream is difficult, it gets in the hair, where a lotion regularly is much easier. But change your shampoo and regular creams, etc. Okay, I think that comes to the end. Again, I hope that was helpful. We will put this up online, and if you leave your contact, where you registered, we will send you a link to the talk, so you can access it and share it with anybody. Again, I'm at Parkview. That's my contact details there. That's my website. That's my email. If anybody has any follow-up questions or any queries, then do feel free to contact me. But I think we'll come to an end now. Thank you for your questions and your interaction. Thank you very much. Thank you, Dr. Zeno.